Welcome to our webinar series for professionals.
Hi. Welcome everyone for this webinar in regards to irritable bowel syndrome and diagnosis around it, and also a bit of the history in regards to diagnosis around it. So today I have invited, and I'm happy that Dr. Pimentel wanted to entertain us today or educate us today around these issues. So Dr. Pimentel is a professor of medicine at Cedars-Sinai and at the Geffen School of Medicine, University in California. And he's also the executive director of the medically associated science and technology program at Cedars-Sinai. And I have actually, so it's a heavy knowledge we've got going on here. So I'm very honored, and I actually heard I've heard a couple of presentations from Dr. Pimentel. For the first time, it was on a podcast, and where no faces, no, just a name. And I remember the name, and I remember some of the knowledge that was shared. And I just thought, oh, that's very interesting. And I was learning a lot. And some of you already know that I did my master's thesis in irritable bowel syndrome when I did my master's in nutritional medicine at Surrey University. So there's a link there as well as to why do I listen to podcasts about IBS and etc. But it's kind of my hobby, and that's probably why I bring in the word entertainment, because I just love this. I feel entertained when I'm learning everything about gut, etc. So having said that, then I just want to pay some of you attention to, or those of you who wish to travel to Copenhagen, that we on the 10th of June have a one-day education in regards to mold and mold toxicity and treatment of mold issues in humans, where Shania is coming to Denmark and is educating in person. So sign up. It's in our education area in the BMS portal, where you can find it there. Otherwise, just reach out to us, and we are sending out emails around it as well. So it would be nice if some of you show up there and we can meet up. So, but for now, I will pass on the screen for Dr. Pimentel. And as usual, we are recording. I'm just double checking. And then also you can put your questions if you have any, or comments, or anything you wish to add in the chat. Then I'll put together questions for sure at the end for Dr. Pimentel for the Q&A. So I will mute myself, but I will listen in the whole presentation, Dr. Pimentel. So I'll let you unmute yourself and share your slides.
Can you hear me?
Yeah, I can hear you. People are nodding, yes. We can hear you.
So, thank you. Very nice to meet you all. And I look forward to hopefully telling you a little bit about this new test, IBS Smart. I think that was what I was guided to talk about mostly, so that you could understand how it works, and also how important it is and has become so important here in the US and other parts such as Canada and Mexico. So as Anne pointed out, I work at Cedars-Sinai in Los Angeles. This is a tertiary care medical center, and I run the Medically Associated Science and Technology program, which is a research institute. We have about 25 staff, all doing research, trying to find the causes of these conditions of the microbiome and irritable bowel syndrome, among others. So if you go back to 1996, so now we're starting with some background. In 1996, which is around the time I started my fellowship, this was what was thought of IBS, is that we don't understand what's causing it. So it must be anxiety, depression, early life trauma were things that were attributed or even considered a cause of irritable bowel syndrome. And that the most egregious is that it was considered a female disease, because there were more women who had it than men. although not that much more, but certainly more. And quotes like IBS is a disease of hysterical women were not unheard of, and I've heard it said by more senior physicians even recently, which is shameful, but it was the way it was in 1996. The other thing that was a challenge for IBS was we didn't have a criteria. There was no diagnostic ability to say you have IBS. And so these experts got together and decided on a criteria called the Rome criteria. If you're not familiar with it, I can speak more on it. But essentially, they created these symptom criteria. The problem with symptom criteria are that, and the symptoms are abdominal pain, constipation, or diarrhea, and bloating. So if you have a symptom criteria, then all you can do is develop drugs for symptoms. You can't develop drugs for cause because the disease is not cause-based. The example I give is if you have Crohn's disease, you have inflammation. It's defined as inflammation in the gut. So all the drugs that have been developed in Crohn's disease are directed towards regressing the inflammation, therefore improving the patient. Here, all you can do is regress the symptoms. So everything on the right, all of the lists that I've got here, are symptom therapies. So antidepressants are for the presumed anxiety, but here the focus was on antidiarrheals for diarrhea, laxatives for constipation, and antispasmodics for pain. And in fact, if you look at all the history of FDA-approved drugs up until all with the exception of rifaximin, IBS was treated, make the patient have more diarrhea if they're constipation, make the patient have more constipation if they have diarrhea. And so we really started off on many wrong feet. But I want to regroup because the focus of the Rome criteria are really on pain and the bowel pattern, whether it's constipation or diarrhea. And what we now know is that bloating is basically universal to IBS. These two studies, which just came out last year, the study on the left was among 88,000 individuals, on the right, 55,000, by the Rome Foundation, by the way, the people on the right. And so this is the group that developed the Rome criteria. And what they tell you, these two studies, is that bloating is the primary symptom of IBS, and yet the focus had not been on bloating all these years, except for the work we've been doing. But when you have bloating, you have to look for causes. And so this guidance from the Rome Foundation also says that you really need to look for malabsorption or bacterial overgrowth or one of these conditions. Well, since 1996, we've spent decades figuring out the pathophysiology of IBS, or trying to. And what we now know, and I'm sort of giving you the spoiler slide, which tells you the whole story, and then I'm going to explain the whole story. But we believe that food poisoning and the toxin from food poisoning called CDTB, when you get exposed to it, it leads to autoantibodies to a protein called vinculin. And then that vinculin antibody results in a reduction in specialized cells of the gut called interstitial cells, and specifically the one type of interstitial cell, which is responsible for the cleaning waves of the gut. And then you get a buildup of bacteria in the gut, and hence this is how IBS is a microbiome disease. So let's take these pieces and I'll try to explain so that you understand how the story evolved. But food poisoning is a cause of IBS, and I fast forward through many studies to come to this 2017 meta-analysis. And in this meta-analysis by the Mayo Clinic, if you pull together, and the top is the bacterial gastroenteritis. So in other words, you got food poisoning from a bacteria, let's say Campylobacter or Shigella or Salmonella. And then people are followed over time in these prospective studies. And in fact, they do develop irritable bowel syndrome. The data on protozoan viral are a little less evidence-based because there's smaller number of studies, as you can see, but the bacterial really is the most common. And it boils down to this: if 100 people went to a wedding and the food was spoiled, and 100 people got food poisoning, 11 out of 100, or 11%, would develop irritable bowel syndrome. Now, we don't know why only 11% develop IBS. It could be genetic. There are some genetic markers that have been found in this scenario, but they're not confirmed. So before I jump to this, the problem with this is that if you get food poisoning and we follow you, 11% of people develop IBS. But what we don't know is if in my clinic in the next month, if I see 100 IBS patients, how many of them came from food poisoning? So that's a more important question. What percent of the entire IBS population is food poisoning the cause? And while we don't know that answer, we have done mathematical models where we've taken the Center for Disease Control data on food poisoning and then layered that on all the data that you can see here on how food poisoning evolves into IBS. So in the United States, and I believe it's the same where you are, if somebody gets Campylobacter, it's reportable because it's a very severe pathogen, and you have to report it to the government. So the CDC has all the data on how much Campylobacter occurs in the United States, for example. So what we did was we said, well, let's take the Center for Disease Control data, assume 0 people in the United States have IBS, and then look at how long it would take to reach a steady state with the level of food poisoning we have in the US, and then see how much IBS would develop over time. And after about 10 years, the curve, as you can see on the right, reaches steady state. These are the equations that were developed. And 9.1% of the entire US population, with the already known incidence of food poisoning in the United States, would have IBS. So you could say, if we assume that about 15% of the US population has IBS, although that number varies, about 60% of IBS comes from food poisoning. And we do believe that's the number. So about 60% of the diarrhea IBS is coming from food poisoning. But does bacterial overgrowth lead to the changes in the microbiome for which rifaximin is effective? And so this goes back to 2008. So this is now a number of years ago. Obviously, we've been thinking about this a long time. We gave Campylobacter to rats on the right. On the left, we gave them placebo. And then we followed them over 3 months. First of all, they had to clear the Campylobacter, then we followed them over 3 months. And then we looked at their stool to see if they had diarrhea or not, and what the diarrhea level was. And then we euthanized them and we looked at the bacteria of the gut. And we found that 27% of the rats who got Campylobacter now have bacterial overgrowth in their small intestine, whether it's ileum, jejunum, or duodenum. But what was more interesting is that if the rats received the Campylobacter, which is the C+, and developed bacterial overgrowth, which is the SIBO+, 84% of them had basically diarrhea. So we, for the first time in history, were able to create an animal model where if we give food poisoning to the rats, they develop IBS. And the only other thing they developed was increased rectal lymphocytes, which is the only thing we see in humans with post-infectious IBS. So the rat model, as you will come to know as we continue through the slides, is absolutely synonymous with human IBS, because everything about this model in rats is the same as what we see in IBS. And these are just the first 2 pieces of evidence. But what's interesting is we wanted to know how, because we know bacterial overgrowth comes from a motility problem, the lack of cleaning waves. But the cells that make the cleaning waves go are the deep muscular plexus interstitial cells of Cajal. or DMPICC. You can see them at the top panel here. The arrows indicate the cells, and they are connected. And they basically, by being connected, they're cells that create an electrical pacemaker of the gut to get the cleaning wave started and to propagate the cleaning wave through the small intestine. And you can see that in the Campylobacter group that also had an overgrowth. They had the lowest density of interstitial cells of Cajal of this type. And you can see down here, you can hardly see them. Maybe you find one in this whole section. If they got Campylobacter but didn't develop SIBO, you can see them. They're there, but they're more amorphous, less formed. And so these are the cells that make the cleaning wave of the gut. Now in 2022, this feels like it's jumping around a little bit, but the essence of this idea that food poisoning causes IBS has to meet a certain criteria threshold. So in other words, if you want to say that food poisoning causes hair loss, you have to meet all of these criteria to say food poisoning causes hair loss. And this test, called the Bradford-Hill criteria, is very clearly met for Campylobacter causing irritable bowel syndrome. And that's the purpose of this paper. We now know for a fact that this is true. But the devil's in the details. So trying to understand how this happens. How do you get from food poisoning to this change in the microbiome, and what are the mechanisms that cause this? So the first oddity of food poisoning and IBS, if you go back to that list from the Mayo Clinic study of bacterial gastroenteritis, any one of these 4 bacteria pathogens can lead to IBS. And you look at them under the microscope and they're very different. This is Shigella on top, Salmonella, Campylobacter, E. coli, pathogenic E. coli, I mean. And they all are different. But so in the 2000s, I was looking for what was common. What was the toxin they all had? Because why would they all do the same thing? And so we identified this toxin, cytolethal distending toxin B, which all Shigella has, all Salmonella has, all Campylobacter have, and only specific E. coli, pathogenic E. coli have. So not all E. coli have it. And so this became an interesting toxin for us, because what we did is we repeated the experiment of infecting the animals with Campylobacter, but this time we took the Campylobacter and we deleted the gene for this toxin in the Campylobacter. And sure enough, the animals did not get IBS. So we knew this toxin had a role in the development of IBS. But what we thought of in the beginning was that this toxin was killing the ICC cells. That's what it was doing. It was a direct toxicity to those cells that make the cleaning wave, the cells that I showed you here. The toxin was attacking them. But in fact, that's not at all what was happening. And I'll get to that in a second. So before I get to that, what we know in irritable bowel syndrome with bacterial overgrowth is that these cleaning waves are deficient. The cleaning waves we've been talking about, the migrating motor complex. So when you wake up in the morning and you haven't eaten breakfast, and you hear that gurgling sound, that's the cleaning wave. Don't stop it. You know, people say, oh, I better eat something so it can go away so I don't embarrass myself with these sounds. But this is the cleaning wave that's coming through the bowel and getting rid of all the debris from yesterday, from the salad and other things that you've eaten that you can't digest, needs to be swept into the colon. It's sort of like your dishwasher. And you can see in IBS patients with SIBO, they have a much less frequent MMC. But it's even more than that, because 50% of the IBS subjects, we didn't detect any during 6 hours of recording. And this wave occurs about once every hour and a half. Not only was the wave deficient, it was immature. It wasn't as long as it should be. It wasn't as perfect as it should be. So the waves were, even the waves that were coming, were not ideal. And we've known since 1977, apologies, 1977, that bacterial overgrowth occurs if these cleaning waves, the migrating motor complex, are absent. So is it the CDTB toxin is the question. So we talked about the study where we deleted the toxin and the rats did not get IBS, but is it Campylobacter plus the toxin, or is it just the toxin? And so we did this study where we purified the CDTB toxin, and like a COVID vaccine, we gave the vaccine or the CDTB toxin to rats in their back under the skin. And then about 3 weeks later, we gave them a booster, just like the COVID vaccine. It was 3 weeks later, you get a booster. And so the rats, of course, are going to develop antibodies to CDTB. So if you look on the left, this is before immunization. They have no antibodies to CDTB. After, they did develop antibodies to CDTB. But oddly enough, they developed antibodies to vinculin as well, which is a protein in ICCs and also other parts of the body. And so they developed autoimmunity to vinculin. Not only that, but they developed bacterial overgrowth. So remember, Campylobacter, if you get food poisoning, it's in your gut. It's producing the toxin in the gut. In this study, we gave the toxin under the skin of the back, and still they developed problems with the gut, suggesting that it's the toxin and the antibodies to the toxin that are causing the gut dysfunction and causing the overgrowth. So when I said it was confusing earlier about was the toxin directly damaging the interstitial cells, well, it wasn't. It was causing antivinculin antibodies, and the antivinculin antibodies were damaging the interstitial cells. And now this makes more sense, because if you have a toxin and you develop antibodies to the toxin, just like the COVID vaccine, if you have the COVID vaccine, you're going to develop antibodies to COVID. And then after 2 years, the antibodies are going to be gone. So you will be susceptible to COVID again. So same thing here. Why would somebody develop IBS forever if they only developed antibodies to CDTB? They need to develop an antibody against themselves that therefore would be ongoing, leading to the chronic disease that can be forever. And we actually, over about 5 years, it took to figure out, we had to get special stem cells from Emory. We had to then apply the anti-CDTB antibodies. We had to find what protein in the interstitial cells it was binding to, and we identified vinculin. And this was a very long process to identify vinculin. So I'm going to talk a little bit about vinculin and how this works here so that you understand. But the CDTB toxin basically is your first exposure. You form antibodies to CDTB. You don't like anything about CDTB. It's not your protein. It's a bacterial protein. It's a toxin. So you form antibodies to this part, to this part, to this part. But this part looks a little like human vinculin. And that's called molecular mimicry. This is not the only example of molecular mimicry. There are many in the scientific world for various autoimmune diseases. And so this similarity leads to this antibody. Now, so what we decided to do is we said, well, let's develop these antibodies. Let's make human vinculin, anti-vinculin antibodies. Let's make anti-CDTB antibodies, and then label them with fluorescence and put them into an animal and see where they go. And so we did that. And what we found was, whether it's the CDTB antibody or the vinculin antibody, the antibodies go to the gut. And then when we took the gut out and put it under the fluorescent camera, you can see the antibodies are attacking or binding to the gastrointestinal tract. What's interesting about vinculin, and I'm getting into a lot of details now that I don't normally get into, but there are about 5 different vinculins in the body. And they're called splice variants. And so, for example, in the heart muscle and other tissue, muscle tissue, vinculin is this form, 150 kilodaltons. It's longer, it's a bigger vinculin. But in the small intestine, in the ganglia or the nerves of the gut, it's this one, the 117. And this is the one that the antibody forms to. It does not attach to this one. Imagine if it did, you would have problems with your heart and other issues. And so it's a very specific antibody for just this gut vinculin. So just to show you, this is from our lab. This is a immunofluorescent stained group of cells, and cells are reaching out to each other. You can see they're reaching out and then attaching to each other. And you can think of the nerve network of the gut or these ICC cells doing the same thing. They're growing into each other and then attaching, like connecting wires, because these are electrical signals that they pass through to create the cleaning wave to make the muscles move. The green are the actin filaments or the skeleton of the cell. And the red at the end, you can see the red there, is a little motor at the end of actin, but that motor or one of the proteins in that motor is vinculin. And so vinculin is important for making sure the nerves can reach out to each other and grab on. Okay, so vinculin is important for keeping those nerve cells and the nerve circuitry intact in the gut. So we did something. What we did was we repeated the CDTB immunization experiment, and this just got published about a month and a half ago, 2 months ago. And we created in the rats, again, they didn't have antibodies before, they now have antibodies to CDTB. And what we then did was in this larger study, we were able to show that the rats got diarrhea, but importantly, the higher the antibodies were, the more diarrhea the rats had. But in this study, we were able, because now we have the technology in our lab, able to look at the microbiome. And what's fascinating is you can see, this is the control rat, this is the CDTB rat. No difference. The antibody to CDTB and vinculin and what's going on in post-infectious IBS does not affect the stool microbiome. So you can't detect these findings using a stool test. All the differences are happening in a larger way in the ileum and in the duodenum or the small bowel in general. And so what we found was happening was in this post-infectious rat, the rats were imagine the rats are the people going to the wedding. Okay, so they go to the wedding and they get Campylobacter or CDTB toxin in this case. And after the wedding or after the CDTB toxin, the rats, some of them are fine. They're the green dots. They're the same as the controls. So they don't change. They don't become abnormal. But some of the rats go to cluster in the blue, which is an E. coli predominant microbiome. And we know E. coli is the hydrogen producer of the gut. And that going up means you're going to have more hydrogen production and gas, et cetera, from that source. But a third cluster is this cluster, which is the purple. And the purple is a hydrogen sulfide cluster because desulfovibrio in the rats went up. Now, I'm showing this because this is exactly the three clusters we see in humans when we look for overgrowth and we're doing sequencing and microbiome analysis of humans with IBS or small intestinal bacterial overgrowth. So the rat model mimics everything we see in humans. But when we look at the rat model, now we've injected CDTB into the back of the rat. Again, I'm emphasizing that, not in the gut, in the back. And then when we look at what's called transcriptomics, we're looking at now the intestine tissue of these rats and what's going wrong. What is breaking down? What is pathologic about the tissue? And the four things that come up in this model are there's leakiness to the gut, barrier function has changed, and maybe that's leaky gut. motility is affected, and we of course know motility is affected, and serotonin specifically, and we know serotonin's an important part of irritable bowel syndrome. Chemicals that are involved in pain control in the gut or visceral hyperalgesia, well, that's IBS too, and changes in circadian rhythm or clock genes in the gut. And so these are all the things, and the findings are the things that are found in humans with IBS. So again, it's the same. Now, this is being presented in about 2 days at the DDW meeting in Washington, D.C., so it's close enough that I can present this. So you're the first people in the world to see this. I just want you to feel special for a moment, because this is very interesting and very cool. So these rats that we gave CDTB to, we wanted to show whether rifaximin would work, but we wanted to show whether rifaximin plus NAC would work better. Why? Because those bacteria that we find in these rats, they don't live in the liquid part of the small intestine, they live in the mucus. And by breaking the mucus, we can get to them better. And I don't know if it's easy to see, but you can see down here, these are the rats that got rifaximin and NAC, and their bacteria goes to normal. Rifaximin alone did not make them normal. You had to add the NAC. And you can see this is the bowel habit of a normal rat. This is the bowel habit of a rat who got CDTB. This is the bowel habit of a rat who got CDTB and then got rifaximin. But look how normal it is when they get rifaximin and NAC. And so for the first time using this animal model, we're able to show that the development of these antibodies leads to the bacteria, but you have to treat this with rifaximin plus NAC to get the best effect. So that'll be an important discovery at this coming meeting. Okay, so now we know all this scientific information. Can we use it to develop a blood test for IBS? How does that work? So we measure these antibodies, the anti-CDTB and the antivinculin in humans in this study from 2019. Now, what I will say is we developed a blood test like this called the first generation test, and it worked. It did separate IBS from other conditions. The problem is, what we didn't realize is that the proteins, vinculin and particularly CDTB, are very funny meaning the little part of CDTB that the antibody binds to, or the parts of CDTB antibody binds to, are hard to get for the antibody when you do it in a dish. In the body, it's different. And so we did what's called epitope optimization to allow those areas for the antibody to bind to be more exposed in the assay. And that improved the test. And this is the improved test. So Generation 2 IBS Smart is the only test that uses that epitope optimization technology, which is a trade secret for the company. So, but you can see we are not comparing IBS to healthy. We're comparing IBS to sick people. So these are Crohn's or ulcerative colitis patients. So if you have a diarrhea patient in your office that you cannot explain, and you did this test and it was positive, the question is, how right are you that it's irritable bowel syndrome? And that's how it should be used, because it is head and shoulders above. But I want you to focus on the top part first before you go to the bottom. We do what's called a post-test probability analysis. And the post-test probability analysis is based on the likelihood ratio. So likelihood, people talk about sensitivity and specificity all the time, and most people understand what that means, but they don't understand what likelihood ratio is. Likelihood ratio is more important because it takes out the issue of the difference in prevalence. So IBS is way more common than IBD. So by chance, you're going to have more positive, because chances are it's IBS, because Crohn's is less common. The likelihood ratio takes that out. But it allows you also to calculate the post-test probability. So if either is positive, you're in the high 80s for post-test probability. If both markers are positive, it's 98% certain you have irritable bowel syndrome. Medical certainty is 80%. That's the definition of medical certainty. If you have a test with an 80% or greater post-test probability, then it is medical certainty. Now I want to talk about this part, because people say, well, it's a very specific test, but it's not very sensitive. If you look at the and or, sort of like this table, it's 56%. And I said, no, that's perfect. And they said, well, why is it perfect? And I said, because out of 100 IBS patients, only 60 came from food poisoning. And we're hitting 56% for sensitivity. So we're right on. So we're not diagnosing IBS. We're diagnosing IBS, and that IBS came from food poisoning, not that they just have IBS. So that is an important factor for you to put in your mind. And so the other thing that this emphasizes is this test takes 56% of, in the United States, the 45 million people with IBS, and says, you have IBS, you don't need to do a colonoscopy or all the other expensive, crazy things that your doctor wants you to do, because the test is positive, you're done, move on. And it often takes 6 years for a patient, prior to this, for a patient to feel confident that they had irritable bowel syndrome. I'll give you an example. Patient goes to see the doctor. The doctor does colonoscopy, they do an endoscopy, they do ultrasounds, imaging, blood tests, and they come back to the doctor, and the doctor says, you have IBS. And the patient goes home and they talk to their family. Family says, what did the doctor say? Doctor says, I have IBS. So the family says to the patient, well, how does the doctor know? And the patient says, well, yeah, how does the doctor know? So patient calls the doctor back and says, so doctor, how do you know I have IBS? The tests are all negative. The doctor says, well, I'm a doctor. So that was the answer, because they met the criteria, but everything's negative. And so the patient then wants another opinion, because they're not sure that the doctor's correct. They're not sure the doctor is making the right diagnosis. I'm still suffering. The medications aren't working. So this breaks the cycle, because this can get you there. So let me put it in a different perspective. So every test, I'm going to show you every sort of test that's ever been developed for irritable bowel syndrome with diarrhea is here. There was a marker for pain perception. That gets you a post-test probability of 55%. So if it's a 50-50, you've just made it above 50-50. There was a 34 biomarker panel that's no longer on the market in the US. That got you to 74% post-test probability, and that's not on the market. Bile acids in stool got to 78% post-test probability. There was a 10 biomarker panel that was on the market for about a year, and people didn't use it. It was not that helpful, very confusing, because it didn't really tell you why the markers had to be positive. You could have one up, one down in one scenario. You could have these two up, these two down, these three up in another scenario, and it was IBS. And so it wasn't coherent. Putting a balloon in the rectum looking for visceral hyperalgesia, which is a test, is very difficult and very painful for patients. But yes, it can reach medical certainty. There was a study, never came to market, looking at volatiles in stool, and they were able to predict IBS quite well. The first generation of CDTB and vinculin were good, but not great. But now this second generation with epitope optimization gets you to medical certainty, and is the best test on the market. And there is no other test on the market, but basically this is the best test ever made for irritable bowel syndrome. Well, the test has gotten a lot easier, at least here in the US. I'm not sure how it would be done on your side, but this device has made it much easier. People can do this at home. This is capillary blood sampling. This has been validated for the IBS Smart Blood Test. Basically peel the back off, stick this on your arm, press the button, wait 5 minutes, the blood collects in the tubes, cap it, send it to the lab. Very simple, very easy, and an excellent way to do this. So to summarize what I've tried to show you today, the microbiome is a beautiful, diverse network of organisms. There's a beautiful network of nerves and ganglia and cells, muscle cells. And then the invaders at the wedding, the Campylobacter, get into your body, and they secrete this toxin, CDTB. It's not a direct effect of the toxin, but more the production of antibodies that is causing problems. So the antibodies are trying to mop up the toxin. And then after about 3 months, you develop the vinculin antibodies. And we've actually done this in a paper that was published following a patient who developed food poisoning from Campylobacter and saw that the anti-CDTB comes up first, the antivinculin later. And then the antivinculin is the autoantibody that starts to affect the neural network of the gut, and then this leads to bacterial overgrowth. For the first time ever that we're presenting this at DDW in a few days, you're the first people in the world to see this. Also, we have actually measured this antibody over time, because we want to see if over time, if the antibodies diminish, does this improve symptoms? And in 417 patients, 158 were positive. Remember, this is now, we're testing anybody and everybody, right? So you're not going to get 56% because it's not a pure IBS population. It's just everybody with diarrhea. Some don't have IBS. So it's going to be lower than 56%. And among 38 patients who over years had the antibody tested, you can see it, one of them was up to 50 months later. If the antibody, the antivinculin antibody normalized, 75% of those patients had improved symptoms. And what I don't show here is that in some of the extreme antivinculin patients, we gave IVIG or immunomodulators to bring the vinculin antibody down. And in those patients, they also improved. So what I'm trying to say in this and everything that I've told you here is that these antibodies, the anti-CDTB and the antivinculin antibodies, are not markers of disease. They're the cause of the disease, okay? And that's a different type of test, because if I could get this antibody out of all these patients, we can cure IBS. And that's really the future, and we're working on that in the lab right now. So putting it all together, all the things that I've told you, and now I'm going to put it together in a different way, comparing the animal studies to the human studies, this CDTB toxin. You can see that they both, the humans and animals, develop antibodies to CDTB, and they also develop autoimmunity when exposed to this toxin. The higher the antibody, the more sick the patient is. We know that now for a while. They both get a reduction in interstitial cells of Cajal and reduced migrating motor complexes in humans. We haven't done that in rats. We haven't measured those in rats. And that's the foundation for this. And then in rats, remember I told you they developed 2 different microtypes of abnormal bacteria in the gut because of this. In humans, they also developed 2 different microtypes. We published this in 2022. And the transcriptomics, all those things that happen in the rats also are found in humans. And so this is the basis for irritable bowel syndrome. So in conclusion, IBS is commonly a condition that begins with food poisoning. The second generation anti-CDTB antibody and antivinculin antibody, which is only the IBS Smart, there is no other test that uses the second generation technology, is the most accurate test for irritable bowel syndrome so far. And now that we understand this almost completely, new therapeutics are emerging. We are developing new drugs right now, and we have some of those already in testing in animals and in the lab. So we look forward to some new things on the market in the coming years. And so that's the whole presentation. I hope that wasn't too long or too short, but happy to stop and take questions then.
It was perfect because now there is exactly some question and some discussions, because all of us sitting here, we are like some of our we're clinicians and treating patients either as dietitians or medical doctors. And of course, this helps us like exactly that, where it's not just an exclusion diagnosis any longer, but they still come at the moment. And for now, they come with their, I would say, plethora of gastrointestinal symptoms, and they have maybe been told they have IBS, or that there's something in their head or whatever they can have been told in their history of symptoms. So when they enter our clinic, and they may already have some years of these symptoms behind them, or it may, of course, just have occurred within the last 3 to 6 months. But probably what I see the most are those who's had it for several years, or as a kid, or like 20 years ago, the stomach wasn't great, but they could live with it, but then it's just gradually getting worse. How would you then, I mean, when would you then say, let's use this test as the first question? Then I'll move more into like clinical things and treatment strategies are following.
Well, so in my practice, I use it in all the patients with diarrhea. So every patient that comes in with diarrhea, I order the test so that I can, because the most common disorder is IBS. And if I can completely separate IBS immediately, it tells me who to do more investigations in. Because if the IBS test is positive, I stop. I start to treat them in that direction. And the ones who are negative, those are the patients I do a colonoscopy, or I do an EGD, or I start to do celiac testing, which is less common, as a way to save money. As well as I'm more likely to find things on a colonoscopy when the IBS test is written as negative. But one of the things that doctors say, well, I didn't do it in this patient because the patient doesn't recall having food poisoning. My answer to that is, how do you know? I mean, they're having diarrhea now. The first day was diarrhea. It could have been food poisoning. You don't know. You know, people do know if the food poisoning was so bad they ended up in the hospital, ruined their vacation, they were having diarrhea on an airplane, and that's a sharp memory for them. But you may not remember the first case of food poisoning you had. And the other thing I'll say, which speaks to your case, is that every time you get food poisoning, the antibodies go higher. So the other imperative of knowing is you got to tell these patients, be very careful. You know, if you're traveling, maybe you should take prevention. Maybe you should in with every meal, which is what we recommend for our patients, so that you don't get food poisoning and you don't get a more severe illness, because that happens. And one last thing, which I didn't mention, is we have one study where we show because you have IBS, you are 3 times more likely to get food poisoning from the same food that somebody else may not get food poisoning, because it doesn't have enough Campylobacter in it. And so we think that the reason this antibody is created is for the food poisoning bacteria to be able to use you again and again, because it has impaired your gut functions and allows you to be the spreader of Campylobacter. So you're impaired, and you'll get food poisoning more likely again.
Thank you. So then, if the patient is positive, then, because we are, of course, how can we help our patients and treatment strategies, etc. So if we do the test on the patient, it's an IBS-D patient that we have, and we do the test and it comes back positive, then I mean, you mentioned rifaximin, and then with the NAC, some of us can't prescribe, so we would maybe use antimicrobial herbs, etc. But can you allude a little bit to your treatment strategies, just so that we can peek a little bit into your practice?
Sure. So now we're talking about not science, we're talking about experience, because this stuff isn't published. So if I have a patient with positive antibodies, I would give, whether it's an herbal antibiotic or a rifaximin approach, I would give them antibiotics. Now, what we see is if the antibody is 2.5, like 2.5 or above, those patients tend to respond less to antibiotics than patients who are under 2.5 for the antibody. Again, the more damaged the migrating motor complex, the more difficult the overgrowth is to treat. But I would basically start treating them in that direction. But you have no idea how many patients, when they get the test back, they say to me, oh my God, I can't believe I have an answer. I've been looking for an answer for 10 years, and nobody's ever told me why I have these symptoms. And they're emotional about it because the doctors are telling them it's in their head, it's in their head, it's in their head, or here is an antidepressant, and or go do yoga, you're fine, or go relax, do some relaxation therapy. All is great, yoga, relaxation, all great, but that's not the cause for them, and they're very frustrated. So part one is giving that patient the peace of mind. Part two is giving you the diagnosis and understanding that they can't get food poisoning again, it's going to get worse. And then part three is saying, okay, it's IBS, treat it as IBS, and that would be the antibiotic approach.
And low FODMAP, or now you even mentioned NAC as a biofilm buster.
Yes.
Yeah.
You could use NAC alone and see if it helps for some patients, since some of you are not able to prescribe. It's definitely worth a try and might work for some patients. We do see that.
And what dosages would you?
Well, the dosage of NAC is usually around 600 milligrams, and usually 3 times a day.
Okay, thank
So
you.
about 1,800 milligrams per day.
Mm. That's an interesting, because I heard like there was a rifaximin, and then you take it with guar gum so that it stays longer in the gut. And but then what do you think, guar gum and NAC now it's like becomes a
Well, so I'm afraid that the guar gum thing came from a talk I gave a long time ago, where I said that, and then it evolved into guar gum. I know this for a fact, is that bacteria that are well fed are more likely to die from antibiotics, because they're in growth phase. Because antibiotics kill bacteria in growth phase. If they're in hibernating phase, the antibiotics can't get in. So somebody asked me, well, what if we gave them fiber or guar gum to see if we can keep them fed like a prebiotic, get them all in growth phase, and then the antibiotic will be more effective. And then that caught on, but I said, I don't do that. I don't think I need to do that, but some people do. So the guar gum wouldn't be a good way to do NAC, because NAC's basically busting the biofilm, and then the bacteria have nothing to hold on to, so they get flushed out. So the NAC effect is not an antibiotic effect. It's more of a, it's sort of like putting grease on the ladder and trying to climb the ladder, The bacteria have nothing to hang on to.
okay. So it's not like a biofilm. It's not like it's breaking down the biofilm around the
It's breaking the biofilm, which is the rungs of the ladder. So because the E. coli, it has flagella, so it likes to live in that thick mucus and swim around in there, and it holds on, staying there because of that thick mucus.
Super. So there's just a lot of questions like, where can I get hold of the test? And we are of course doing this webinar because we are launching the test in VMS. So you need to log into your DNALife.vms.com account or your Nordic VMS.com account. If you don't have an account, we reach out to us. You will have an email where we're sending out the recording, and just reply to that mail and we can help you get an account with us. And it's also in the UK and it's not just within Europe. So, but reach out to us if you have any questions. And it's only the blood draw that we can offer, not the one on the arm. So that was just a little bit of a service information, because then I have the next question that comes up. And that's this in how do we fix that motor migrating complex, as in fasting could be a thing. Also ginger could be a thing that's supporting serotonin, maybe through 5-HTP, or what's your
So what we do, especially with the higher vinculin, is that we want to, the way I describe it to patients, and feel free to use this, is because these interstitial cells are more sparse in this situation. It's sort of like you arrive at home at night and somebody took half the light bulbs out of the house. So you can't see, it's more dark. So you turn the lights on, but it's very dark in the house. And so that's the analogy, is that the migrating motor complex is not happening because there's too few light bulbs to turn the migrating motor complex on. So one way is to put the bulbs back in, but if you don't have bulbs, you can turn the energy up on all the bulbs. So each bulb is brighter. And that's what we do. We use a prokinetic. The prokinetic, we use Resolor, it might be called in Europe. It's called Motegrity here. So we give that at night. Some people give low-dose naltrexone, which also has that prokinetic action, or low-dose erythromycin. I've used all three to try and make the migrating motor complex. But you were speaking about sort of diet, and fasting longer allows the migrating motor, what little migrating motor complex you have, give it a chance, you know. And sometimes people are eating all day. You never let the fasting cleaning waves come. So our low fermentation diet, which we talk about, it's not just about what you eat, it's that fasting period between meals. So you put 4 or 5 hours between meals, so you can at least give your body a chance to get those cleaning waves. And then I also saw one of the treatments we use is elemental. I see on one of the questions is elemental diet. And so elemental diet is beautiful. I mean, if you don't have a prescription or ability to prescribe antibiotics, elemental diet works better than antibiotics, because it basically gets absorbed so quickly, it starves the bacteria of the gut out. And everything's happening at this DDW this week. And so I'm giving you all the secrets. But we have an elemental diet that we help the company develop, because the elemental diet tastes so terrible for patients. They don't do it. And this one tastes so good that patients love it. In a taste test between this and elemental, it was 300 to 0. They liked the elemental diet. It's called M-Biota, and it just, I believe, launched in Europe this week. Okay. So called M-Biota. So you can take a look. M-Biota Elemental. It's very, very cool. I've even tried it for 7 days just to know what my patients feel like. And it's great. It's easy to take.
Well, thank you for that. I'll definitely look into that and see if we can get that option out to our practitioners for sure. So lots of questions came up, lots of detailed information. And of course, we did the recording, so we will share with all of you. Are you allowed to share your slides, even with some of those preliminary reports on? Maybe
I can share my slides after Saturday, so maybe next week I'll...
We won't send out the recording until next week. So if you're happy to share, then I'm sure everyone will appreciate that for sure, because they're highly detailed, your slides, and if we're going through them by our own pace, it's nice to have them on the side. So. I think time is up now, Dr. Pimentel. That was a very interesting presentation, and so I was very impressed, and I'm eager to start getting some experience with the test in my patients for sure. Everyone out there, if you have any questions, reach out to us in regards to the test. There is like an interpretation sheet, etc. But of course, this lecture should give you enough information and knowledge in order to interpret the tests. And then hopefully I'll see you all next month at a webinar we have with Dr. Nirala Jacobi in regards to SIBO and difficult cases to how to treat SIBO. So it locks very much into this webinar as well, because it's very much interlinked. And yeah, so I hope to see you all then, and reach out if you feel like it, and we will for sure reach out to you. Again, Dr. Pimentel, thank you very much for your time.
Thank you. It's great to meet all of you. Okay, bye-bye.
Bye.
If you do not already have an account with us, please contact our team and we will assist you. If you found this webinar helpful, please like and subscribe to our channel.